us started on the event. Policy Spotlight is a series of virtual events Health Affairs launched last year featuring in-depth conversations with influential health policy experts. We've had recent events with CMS Administrator Chiquita Brooks-LaSure, FDA Commissioner Bob Califf. Most recently, I spoke with the former Commissioner of the New York City Department of Health and Mental Hygiene, Dave Chokshi. If you missed these or the other events in the series, they are recorded and available on our website. I don't want to delay our start any further, so I'm just going to jump in and say that I'm really pleased to have the opportunity today to speak with Dr. Robert Valdez, recently named the Director of the Agency for Healthcare Research and Quality within the U.S. Department of Health and Human Services. AHRQ, as hopefully most of our viewers know, is the agency tasked with producing evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable. That's a lot to do in one small agency, and AHRQ works with partners to help consumers, health professionals, and policymakers make more informed health decisions. We'll talk about the agenda for the agency in our hour together today. Pleased to introduce to you Dr. Robert Valdez, appointed the Director of AHRQ in February of 2022. Previously, he was the Robert Wood Johnson Foundation Professor Emeritus of Family and Community Medicine and Economics at the University of New Mexico. He was the founding dean at the Drexel University School of Public Health. From 1985 to 99, he was Professor of Health Services at the UCLA School of Public Health and Associate Director of the Chicano Studies Research Center. This is not his first time at HHS. He's been Deputy Assistant Secretary for Health and simultaneously the Director of Interagency Health Policy at CMS. I've had the pleasure of knowing Bob for years. Dr. Valdez, thank you so much for joining me today. I always like to start these with just an open-ended offer to give the audience a few minutes on your priorities in this new and very important role.
Well, thanks very much, Alan. And I have to start out by, first of all, thanking you publicly. For those of you who don't know, much of my career has been working with the states and with governors' offices and state legislatures. And Alan was kind enough to come out to New Mexico after the ACA and help us expand Medicaid in the first round of expansions. And it truly is it was possible because of Alan's wonderful presentations and educational work with our state legislators that we were able to accomplish that feat. So thank you very much. And it's hard to believe it's been that long.
It is.
Well, you know, AHRQ is to local healthcare systems as CDC is to public health systems, is the way I like to describe AHRQ. And so my agenda is pretty clear. It's marching orders from really the White House, the Biden administration's desire to really transform American healthcare for the future. And so what I'm trying to do at AHRQ is reorient us so that we can help reverse the healthcare system's worsening performance. You know, this system has fallen short of its potential for decades, especially given the unparalleled national expenditures that we have, comparing our expenditures and our outcomes to other industrialized nations around the world. Now, the pandemic's really exposed some really long-standing concerns of the system: fragmentation, perverse incentives, financial incentives, and structural inequalities that, you know, that had really deadly consequences as a result. And there are a lot of other opportunities that AHRQ is going to be trying to take advantage of to try to reverse this worsening performance. And that is really recognition of our need to engage communities more, to understand their experience in the healthcare system. We're a service industry, and we've got to function like a service industry. That is, knowing what our customers need and want, and being much more responsive to it. We need to tap into the digital healthcare potential. We saw some of that occur with the pandemic when we started adopting all kinds of telehealthcare arrangements, and trying to understand how those work, where they work, and how best they work is the work of AHRQ, and to help healthcare system leaders try to figure out where they're going to make resource allocation decisions to make that happen. We also have to help move this rate of evidence mobilization. AHRQ's main job is to create kernels of actionable knowledge from all the evidence, all the studies that are available that you publish in your journal, and turn those into actionable pieces of knowledge that can either be used in the clinic, if it's clinical work, or in organizing and financing the system. But unless we increase the rate of evidence mobilization, we're going to continue at this slow pace, turtle's pace of advancement and innovation. And as you said, AHRQ is really the only agency in the department with congressional authorities to improve healthcare. Now, financial incentives are important. Don't get me wrong. I was at CMS for a long time. I understand them. They're necessary, but they're not sufficient. And so we're trying at AHRQ to really try to address these shortcomings of the healthcare system in new and different ways. So I'm trying to orient our agency to really look at the kind of healthcare we want, not just in the 21st century, but towards the 24th century. If you're not forward looking, you can't get there. So, we really need to think about what we're trying to achieve in our system, how we help our healthcare decision makers get there. And one device and one element of that is really recognizing what the pandemic has done. The pandemic has really exposed issues of patient and workforce safety. And so we're going to try to grab a handle on that. We've been part of a national coalition that's developed a national action plan for, reinfusing workforce safety as really a organizational approach to focusing on how we increase and improve healthcare in the United States. So we're going to be trying to build this alliance. We hope you and your audience and all of the health services researchers recognize their home here at AHRQ, that we need your advice, you need your suggestions, we need your work, and we certainly want to fund a lot of that research that you can publish later, but we want to turn that published research into actionable knowledge.
Well, it's a great way to start. I want to ask some sort of high-level questions. I will say to the audience, if you're watching live, you can put questions in the Q&A box. I'll try to get to as many as I can if they're short and come in on the earlier side. And of general interest, I'm more likely to be able to weave them into the conversation. I really appreciate your reference to the importance, but the limitations of financial incentives, because it does seem sometimes like that's all we talk about. Sometimes that feels like all we publish. You're talking about engaging with systems, and I look out at this, vast multiplicity of actors and players and roles and all the divisions and all the specialties and all the conflict across payers and providers. And you've got this one small but mighty agency. So when you think about moving the system, what are your points of entry? Where do you even start a conversation about moving the system?
Well, it's an area that I think AHRQ hasn't done enough of, and that is really beginning to talk to the healthcare executive and C-suite folks who operate systems, and to recognize that these systems are local systems. All healthcare is local, so we need to actually deal with those local decision makers, because it's those resource allocations at the local level that make innovative technologies possible, adopted, the room you need, the people you need, because every community doesn't have all the pieces, all the same pieces. And so every community organizes itself in a slightly different way, depending on what resources they have. Rural communities and some disadvantaged communities in urban areas don't have pieces, even though the pieces are around. So organizing them, helping those systems leaders understand where they can and efficiently organize and deliver services is a point of entry that I want to try to get AHRQ to re-engage with. We've spent most of the last decade, as you suggested, really focusing on the clinical aspects of care improvement, without also looking at, well, can we actually get that clinical innovation into a healthcare delivery system or into a healthcare setting at a faster pace to help reduce costs, to help improve efficiency, or whatever it happens to be that particular innovation allows. So that's my point of entry. It's also my natural point because, as you know, over the years, I've trained health services researchers and health services managers. And the two need each other because healthcare managers need to do improvements based on evidence. And that evidence needs to be provided by the health services researchers in our community. So it got to go hand in hand, and we need to get those hands back together again because they've been separated far too long.
I feel like back before COVID, when I actually went to conferences and meetings and we were talking about health system improvement and various initiatives, I often felt like I saw the same people at meeting after meeting, the exemplars, the leaders, those who probably were in the tightest circle of creating and using evidence along the lines of what you do at AHRQ. I wonder if you feel that the reach, as you say, into the community, not just the most high performing and highest resourced institutions, but that the ones that serve, most Americans, whether they have the resources to engage with AHRQ, what you bring to the table for those who maybe don't have as much infrastructure as an academic medical center or a highly resourced hospital.
Well, I just had this discussion in Iowa, and I met up with a number of healthcare executives in Iowa who didn't know that AHRQ existed, didn't know that they could go on the website and find a lot of decision support tools for their clinicians, as well as support tools for their patients, as well as support tools for their own management structures. And it's government paid for, it's all built. Unfortunately, we've had, like many agencies do, we build it and assume that they will come. And we've really got to change that approach to doing business. And I hope we can do more of that to reach out to those healthcare providers that you're talking about who have less resources available. We're really looking at ways in which we can use our P4 trust fund dollars to do much more active dissemination and implementation assistance work than historically we have, because much of the dissemination and implementation work that has been done through the federal government has followed this sort of model of build it and they will come. And so as you well know, I like to go and take resources to where people are. And I'm hopeful that we can begin to look at how we can do that in an efficient way using those funds that we have through PCOR. Trying to do that with our regular budgetary dollars is hard to do because we are, like right now, we're on a continuing resolution. So luckily we've positioned ourselves so we can continue to do the work that we need to do. But we certainly couldn't move very fast if we had to rely solely on those dollars, as you know.
Well, I actually do want to ask you a little bit more about the PCOR Trust Fund, but I before we go there, I actually had a question in my mind, and then someone in the audience asked a variant on it, and so it must be a good question if our audience is interested in it as well. When I think about the High Tech Act and its investment in the technology infrastructure, hospitals essentially all have IT systems, physicians' offices. The rates went way up with high tech. Mental health providers, social service programs that health systems increasingly interacting with, not so much. The question that came in had to do with the need for team-based care involving pharmacists, social workers, dietitians. So maybe it's just a bit of a reframing of my earlier question. You talk about health system leaders, you talk about going into the community. Within that community, again, there's a range from maybe the community hospital to, the physician practices, but also dentists and pharmacists and dietitians and others. Are they all in your circle? Do you want them in your circle? How do you get them in your circle? How do you think broadly about a team-based healthcare system?
Well, you just described one of those main issues that I talked about at the beginning. That is the fragmentation that severely affects and plagues our healthcare delivery system. And trying to address that fragmentation I've looked for a number of ways in which AHRQ can begin to provide some support and examples about how to make us a much more integrated delivery system, no matter which of the kinds of pieces you have available in your community. One of those handles happens to be one of the priorities of the president and the department, which is our response to COVID. AHRQ is particularly taking a look at how we deal with the 24 to 40 million people who may have long COVID and who are looking for care and looking for services now, while we're still trying to figure out what the underlying biomedical issues are that my colleagues are researching at NIH. But we can't wait for NIH's discoveries. We've actually got to figure out how to put multi-specialty care and primary care together in a way that serves folks. So we're exploring ways and working with systems around the country to look at different models in which that fragmentation can be reduced. We're also very much involved in trying to pursue this effort to expand access to high quality and affordable healthcare that the president has had us pursue, and in particular to look at how one integrates behavioral and mental health care, which is in desperate need as a result of the pandemic, but was in desperate need before the pandemic. But as you suggested, many of those care providers don't have those IT systems, aren't connected to the payment systems that the physical healthcare folks are. Here at AHRQ, we've been working for quite some time on how we in fact can integrate behavioral healthcare into primary care and make it easier for behavioral healthcare providers and mental health providers to have the kind of IT support and the kinds of billing structures that are necessary to be part of this larger system that they have largely not been a part of. And so AHRQ has been, and our partners throughout the agency, because this is really a departmental initiative, have been looking at ways in which we can help to integrate behavioral and mental health services with physical health services. It's not easy, and I think there are lots of different levers available. And certainly AHRQ has been trying to contribute ideas and tools and a learning environment and learning communities of primary care clinicians, as well as behavioral health clinicians who have been working through their particular local issues. Because as I said, all healthcare is local. So they've got to figure out those local adaptations to make it work. And we're trying to make playbooks available and tools available across those care providers. So those are just two examples of other things that we're doing. We're also working with nursing homes where they've largely been left out of the equation. And particularly the workforce has a whole lot of needs. So we've been trying to figure out how do we link that nursing home, long-term care, rehab issue and the hospitalization, because that transition, as you well know, is problematic in many cases.
So a critical element of engaging communities is engaging patients and people where they live in those communities. You know, AHRQ has this long history of working on patient experience measures, but we are also in a time of new technologies for collecting data, different ways of analyzing data. We still use CAPS and the CAPS forms that you get in the mail after you've had services. Do you see in the health system of the, what was it, the 24th century that you're looking at? I don't think I can even get my head there, but as you look ahead, where do you see AHRQ going with patient-reported outcomes?
Well, you certainly hit on a topic that is a hot discussion here, and I'm trying to get us to rethink how we begin to make not only better ways of data collection, but how do we make it more available in real time? Because it's healthcare decision makers at the C-suite level or clinicians, right? On the clinical side, we're doing a better job of creating clinical support decision tools. On the management resource allocation side, we've kind of fallen behind. And that's particularly true if you're talking about it at the health systems delivery level, or if you're talking about the state policymakers who need, better information. On the state policymaker side, we've got an interesting investment in an all-payer data system, particularly the creation of a synthetic database that we recently just released for people on a beta basis to try out, recognizing that about half of the states have an all-payer system and the other half don't, and there are critical decision-making opportunities there if they have the data. What people don't recognize is that those all-payer systems that do exist have holes in them. They're not actually all whole payers, but AHRQ does have access to fill those holes. So by building this system, we can help the states that already have systems, and we can also help the states that don't have a system and that rely on sort of the synthetic approaches. Of course, the synthetic approaches always raises concerns, but that's why we do sensitivity analysis, and we look to the health services research community who's watching today to help us figure out how to do this better. You're definitely right. We need to do a better job of capturing the patient experience. There are new technologies available now than the way that we started collecting patient experience. Looking at patient experience only from the clinical perspective, as I suggested earlier, isn't sufficient either. It's necessary, but it's not sufficient to really understand the experience itself, because the patient is no longer just that cowboy patient of the patient-centeredness that we've talked about historically. And here's what I mean.
Yeah.
We've made some great strides in looking at, team care on the professional side, recognizing that no single care provider can do it all. Well, there's also a patient team. No single patient can do it all. That conceptual model that we had of the patient being the cowboy patient, where they advocated for themselves, they moved around themselves, they organized the system for themselves. I've never met that patient. That patient is built around this notion of being completely independent and strong-willed and able to work through their illness and make everything happen for them. In my case, the patients I've seen, and certainly my own family experience, whoever's been ill required support. They needed a team. And so increasingly, we need to realize that we're dealing with two teams that need to communicate well in order to create optimal healthcare outcomes. And part of what we're doing at AHRQ is also recognizing that patient team. We've built a number of tools to help patients get the most they can out of their visits with their health professionals. For example, one of the best tools that we've developed is this question builder tool. Now, when my mother had breast cancer diagnosed at the age of 86, I used to sit at the table with her, and we'd sit there for hours, and she'd jot down on this little paper with paper and pencil, and then we'd go to the doctor's office, and then she could, unfold her little paper and try to find it. After about a year of trying to convince her to get a smartphone, we actually popped in a variety of other things, and we put the builder in there, and she could, whenever a question occurred to her, she could just pop it right in. And so when we went to have that interaction with her oncologist, it was a much richer communication. It was a much richer experience for her, and it was a much better experience for the clinician, who could take his time, answer her questions, and make sure that she was able to follow through. Not follow through with just me, but because my mom had the question builder, she could tell her sisters on the telephone, because she'd call them 3 or 4 times a day. And so they would compare notes. And so, we have to build those kinds of tools to help with the patient experience and the patient team, so that patient team and the health professional team can really work together much better.
Well, that's a really helpful way of thinking about it. And you're absolutely right. Of course, we've changed how we think about it on the clinician side. We need to change on the patient side, and the complexities on the patient side are just as great as complexities on the clinicians, health system side, in the sense of who is the leader of the team and what information is shared, and
Yeah, and
are
the other,
people's experiences consistent or dissonant, and what does that mean? We could have a lot of fun with this
well,
topic.
the other issue is that, we, as you know, I came from the University of New Mexico, where I'd been teaching medical students, and we're still using protocols that look at one problem at a time. And I've never seen a patient come in the door that didn't have 3 or 4 chronic diseases that they're trying to deal with, and sometimes with 3 or 4 different specialists or providers. So, we've got to recognize, in an aging society, people are going to be bringing to us different kinds of puzzles that need to be solved. And we need to develop those protocols for people who have complex health conditions, and recognize that presenting problem may not just be the only thing that needs to be dealt with in that visit. And how we organize ourselves and organize our care delivery requires us to think differently than that single problem protocol approach. So that's partly why we're trying to deal with this issue of, sort of, the long COVID is a great sort of example of that kind of issue, where people have multiple things happening. They require multi-specialty attention, but they also require us to really understand how to put together complex care for complex issues.
We noted at the outset the incredible breadth of responsibility for AHRQ. I want to spend a moment just trying to understand a little bit better the relationships, interactions with some other enterprises, entities that you must bump into and need to coordinate with. You mentioned the People Trust Fund, and I'm curious how you think about the AHRQ role with respect to that relative to the PCORI, what PCORI is doing in patient-centered outcomes research. How do you navigate the relative responsibilities of what you do and what they do? I've always wondered about that.
Well, it's we're lucky we have some really great new management at PCORI, and PCORI is one of 3 organizations that receives funds from the PCOR Trust Fund. ASPE receives a small share of funds that helps build infrastructure, data infrastructure here in the Department of Health and Human Services. PCORI has funds that are dedicated to funding the actual research projects. And AHRQ has been dedicated funds to do dissemination and implementation work, and also the training of the future PCOR researchers. So, we've for a long time at AHRQ supported fellowships for young scholars and mid-career scholars and even senior scholars. And so the trust fund allows us to provide some additional support to continue to invest even deeper in implementation science, and to do more of what we've started to do, which is programs that embed health services researchers in healthcare, learning healthcare systems. And so developing that link also means that we can more effectively look at how we disseminate and help those systems implement the PCOR findings. And not only the PCORI research findings, but findings that we fund at AHRQ, or that are funded by private philanthropy or elsewhere. We're not restricted from only looking at and implementing PCORI findings. So, as you know, much of what we do at AHRQ is evidence synthesis, and we bring together all the information that's been published in a particular issue or topic, and we try to find that actionable knowledge. And the trust fund allows us to do that more widely. And I'm trying to look at how we can do it differently and more distributed around the country, because, as you well know, there's lots of variation in the way care is delivered around the country, And we need to recognize also that, as I said earlier, the healthcare system in local communities are all different because of what pieces they seem to have or happen to have. So working with those individual areas is something that we're exploring, and something that's possible because of the Pecor Trust Fund.
When I think about dissemination, diffusion, we're of course in the information dissemination business as well, and we often confront a question of how do we know who's receiving it and who's using it. One of our listeners asked, what metrics or outcomes do you use to evaluate your success? We could apply that to all sorts of things, but I am particularly interested in the area of the information diffusion. How do you know whether or not people are getting and using what you do?
Well, unfortunately, we use probably the same metrics you use at present, because up until I started pushing the agency in this new direction, it's mostly been about, well, how many publications have our researchers that we funded published from that grant? Where are they publishing? Are they publishing in journals like yours that influence people to make changes or to reconsider what they're doing? As I said, I want to get beyond our publication focus to actually look at how this information, actionable information, gets into the hands of decision makers. What those metrics are, that's exactly what we're debating here at AHRQ. How we put it together, that's what we're trying to do now. And so that we can be positioned to help move our system to that, well, okay, maybe not 24th century, maybe it's 23rd century healthcare system.
Another agency that seems really relevant to thinking about your work is HRSA, focused on primary care for vulnerable populations. You have an equity agenda. You just talked about people with multiple chronic conditions, higher prevalence in more vulnerable populations. Again, if you look at the descriptions and the missions, the two divisions are really very different. And yet, because you have some shared goals, I wonder how you think about HRSA as a distributor of information, as a partner in achieving equity goals. How does that look from where you sit?
Well, I would like very much, and we've been talking about this, how we can take the tools that we've developed at AHRQ and share them with other governmental care delivery agencies. One is HRSA because of the Bureau of Primary Care, which supports primary health care centers around the country. But there's also the Indian Health Service that historically has not taken advantage of the kinds of tools. And while we have ongoing discussions with them, we've never really sort of taken that more aggressive approach to assisting different tribal communities figure out how to use these. Increasingly with the 638 tribal communities who run their own systems, many of them could use the same kinds of tools that we have available for other local healthcare delivery systems. And so that discussion has recently begun as well. We've been talking and have had a long-term relationship with the VA where we've interchanged ideas, and they're a care delivery system as well that can take advantage of the research that is supported by AHRQ and the actionable knowledge that gets produced here. So increasingly, I'm trying to reach out to my sister agencies that are in the care delivery sphere, as opposed to the science agencies that we're also reaching out to, because much of the work that we do, for example, in our evidence program, helps NIH define its research agenda, different agencies or different institutes. It assists CDC with a number of the kinds of data collection related issues that they do on their public health surveillance. We provide, of course, some of the background evidence that CMS uses for their coverage decisions and for rulemaking. And so, increasingly, we're trying to do that kind of both internal support for the sister public health service agencies, but also recognizing many of those kinds of decisions are also done at the state level. And so increasingly, as you know, I'm a kind of state guy. I want to make sure that we have those resources available to make available to the states that also create their own regulatory environments within which care is delivered and organized.
Going to change topics a bit here. Our October issue in Health Affairs was focused on disability in health. And there's so much here that we learned from doing the issue. I'm curious about the training and capacity building side with respect to serving people with disabilities from a clinician's perspective. We had a number of papers referencing data, particularly the limited data collection on disability and the lack of uniformity and how we collect that, which then is a barrier to doing good analysis. I'm pleased to see that I feel like there's more attention to issues of disability than there was just a few years ago. I wonder where that fits in your thinking about AHRQ's agenda.
Well, I'm glad you raised that because, AHRQ's been involved in looking at this issue of equity. And we started actually looking at the disparity that exists for people with disabilities. And during this last year, we had a director's series highlighting, before you had your publications, I wish we'd have had all your publications and authors that we could draw upon, but we drew upon many experts who are out there and have been publishing for quite some time to bring and raise that awareness to not only to our staff, but also to our sister agencies who tune into our director series. And so we're going to be doing a director series that hopefully you'll do a publication on too, that's looking towards the future and something that we should have been doing for quite some time, which is also looking at our aging population, our aging society, really. And some people call it healthy aging, some people call it active aging. There are a whole lot of names out there, but it's clear that many of the states are ahead of us in thinking about this issue. It's something that I hope that here at AHRQ we can help other states get on board with the agenda. But if you think about the aging issue, it also means that many of us develop disabilities as a result of that aging. And that's one of the things that you see as people get older, disabilities become more visible. It's not just people who have been hurt or who were born with disabilities, but that all of us are actually moving towards a point in our lives where we may suffer or experience a disability. So it's not something that is rare or uncommon. And yet it's something that we, as you pointed out in your publications, in the care delivery system have largely ignored or looked away from.
I'm glad to see it as a priority, and we'll be really interested in watching what you do with it. I know you would anticipate this, but we're a journal and we publish health services research, so I have some slightly more wonky questions. I will say that some time ago we did an analysis of the data sources used for articles published in Health Affairs, and AHRQ data sets were the #1 source. That probably doesn't surprise you, but it is a really critical infrastructure for the health services research community. So let me ask a broad question, then a narrow question, and then we'll probably be running close out of time. The broader question is whether there are data gaps. We talked a little bit about patient reported outcomes and the moving away from the cowboy patient. One of our listeners said, "I don't have a question, but I just want you to know I love that." So I think that's great. But beyond that, are there other places where you look at the data infrastructure and say, boy, this is something we've really got to do better on?
Well, yes, we rely on survey research methods that go back decades for much of our work still. And while we need to maintain those, we also need to look forward about how to collect those same kinds of data elements moving forward. So it's a challenge I've put forward to our data group. It's a challenge I've put forward to our intramural research group, because they need to help identify those areas and those gaps where if they had the data or if they had better data, we'd be able to do this kind of analysis or that kind of analysis. And if our internal group is looking for it, I know our external researchers are certainly interested in it. One of the major areas of gaps is really the supply side of the healthcare delivery system. You know, as we're charged with monitoring what goes on in order to improve, one of the areas that we have very little data on is actually the supply of healthcare professionals. So trying to fill that gap, trying to understand what is our supply of the people who actually provide services. What does that look like? What are the where are the problems? Because when I talk to healthcare executives, they tell me the first issue on their mind is workforce, and the second item on their mind is workforce. And so when asked the third time, they say, "Well, haven't you been listening to the answer for the last two? Workforce." And so there are very few things that very few data elements that are available throughout the federal government to deal with a number of those issues around workforce. Luckily, the Bureau of Labor Statistics has some information, and certainly we've been working with them to gather what's available. But clearly, that supply side of the equation, because healthcare is really about people. Whether you're talking about the patient or whether you're talking about the workforce, it's about the people involved. We need to be able to take care of both the patient as well as the workforce. And so we need a better idea of who's in the workforce. What do they need? What's causing out, what are the underlying issues that are causing all this burnout? Some of it has to do with that patient safety issue. Many people who don't feel safe come into work. And we saw some of those safety issues pop up in many different segments of healthcare delivery. I hate to say it, but there were people going to work at nursing homes who had no PPE, and how unsafe could that be? I mean, that's about the worst thing possibly happen. So we've got to deal with those things, but we also need to understand more about the workforce from a monitoring perspective, not so much from the how many numbers or which our teams at HRSA work on. They work on the educational side and the number side, but we need to understand the work environment of the workforce. We need to understand the concerns, and dealing with a lot of the patient safety issues is really understanding how the workforce can identify the hazards that are in the system, so that it's no longer about blame, about error. It's about identifying hazards within the system itself, so that we can do systematic changes that make things better, not only for the patient, but also for the workforce.
So I'm going to go from that fairly broad question to a narrower one that one of our listeners sent in, and it's a little complicated. I don't want to exactly read it, but it has to do with the shift in our thinking about the collection of data on quality and disparities. Of course, the reports come out of AHRQ. And historically, so many of those metrics have been built around administrative data, claims data. We now have, through high tech, a very robust infrastructure using electronic health records. There are more measures now that are based on real-time transactions, real-time clinical visits, as opposed to the limitations of the claims data. And the theoretical possibility here, now I've got your 23rd, 24th century thinking cap on here, but the real potential here is to shift our thinking about how we measure quality, outcomes, disparities from a backwards looking administrative scrutinizing of claims to a real-time or almost real-time analysis of transactions as they occur. Do you see us getting close to that? Is that on your agenda for rethinking what goes into those reports so that we can have a more timely and accurate picture of disparities in equity and quality?
I certainly hope we can say that by the time I'm done with my tenure, that we've taken great strides in that direction. We've begun looking at ways in which EHR data can be made available not only for analytic purposes, but also for training purposes. There are so many people who are in their health services research training activities or in their clinical training activities who don't know how to use those systems to find the kinds of answers and questions, or don't find the kinds of answers they need for the questions that they have. And so increasingly, we're trying to get at least sample and beta data sets available so at least the analytic techniques can be worked on, while we're also trying to figure out how do we engage with the various suppliers or the health systems themselves to supply that kind of information, similar to what we used to do with the hospitals when we first started the hospital data collection work. That was done on a voluntary basis. People provided their data, we aggregated it, we made it available and cleaned it up. We need to be able to do something similar to that, probably on the EHR side. How are we going to do that? I don't know. I'm sure that the people who are listening have a lot of ideas. I encourage them to write us, let us know what they're thinking, how we should be going about this. It's certainly part of that data challenge that I put forward when I stepped into this role here at AHRQ. And I know I'm driving my data group crazy because I keep asking them for updates on sort of what progress are we making, where are we thinking, what should we be doing differently, where do we need to invest, because even in the computing side, we're still doing old types of computing. Maybe we should be doing supercomputer type movements, which are kind of even old now. But certainly before I came here, I was using the supercomputers at the national labs in order to look at environmental exposures leading to diabetes and to cardiovascular disease. If I can do it that way from the university, we should be able to do much better from the inside here.
So I always close with a question about your career, but I want to sneak one in. The very first question that came in from the audience is whether there are lessons for AHRQ from your experience in New Mexico, which, as the questioner says, bucks the national trend linking higher rates of poverty with higher rates of chronic disease. So since you've said you're a state guy and everything is local, is there a lesson for AHRQ out of New Mexico that you want to share?
Well, I think I tried to allude to that in many of our responses, and that is our AHRQ's need to actually to be a national agency. We've historically pursued our work doing pilot studies with a few states in a few locations, and then never really sort of taking those to scale. And one of the things I was surprised at was there was lots of really good work here at AHRQ, and it's on the shelf. And my job right now is to take it off the shelf and to bring it to scale. And to bring it to scale means I need to engage more and more states and more decision makers at the local level. And we have historically not done that at AHRQ, and we're looking for new ways to do that. Part of that is doing it in partnership with CMS, as they have some of those natural relationships. Some of it may be doing this through our regional health officers in the department, who by and large, I think, would relish the opportunity to engage.
That's great. Well, I always close these conversations with a question about your career path. You've had a really interesting one. It's great that we've been able to interact over the decades. And here you are at AHRQ, which has an incredibly important mission. And as I said at the outset, we spend a lot of time figuring out where to put the money. We spend a lot less time on how to actually improve the systems of care, and that's where you are. I wonder if you could share with the audience one or two sort of consequential choices you made along the way that you think are part of what prepared you best for taking on this critical role.
Well, I first of all have to say thank you to the many mentors I've had over the years. Bob Brook, Joe Newhouse, Arlene Leibowitz, Emmett Keeler, and the crew of the Rand Health Insurance Experiment, who took me on as sort of the youngest lead researcher for the health insurance experiment. I learned so much from all of them, and they were very generous with their advice and their support throughout my career. But I also had some wonderful mentors beforehand. You know, at the different universities that I was at, the University of Michigan, at the School of Public Health there, the work of Avedis Danabedian, which is central to the work that we've been doing here on quality and patient safety, and underpins lots of the work that that led to the quality chasm work that IOM published with Mark Chasson and others. I guess the answer is to your question is never let a crisis go to waste, as I've been taught. And so I've always jumped at the opportunity to be in the thick of things. It was true in the Carter administration, it was true in the Clinton administration, it's been true here. And in between, really preparing myself for that any one moment you get the call either by a governor's office or a state legislator who wants help trying to solve a problem. I guess that's my story.
I think it's a great story, and I appreciate you sharing that. Well, Dr. Valdez, thank you so much for taking this time to speak with me in front of an audience. It's been a joy to be able to reconnect with you after some time apart. I'll say to the audience, we hope you enjoyed the event. We did earlier this year launch Health Affairs Insider, which is a membership program that offers exclusive access to content that goes beyond the journal. If you're an insider, you'll have access to a curated email newsletter on priority health topics, exclusive events, and more. You can sign up on our website. We have some upcoming events that might be of interest on Tuesday, November 8th, in addition to being election day. At 2 p.m. Eastern, we'll have a virtual briefing on a set of research exploring the health effects of economic security policies in place during the COVID-19 pandemic. On November 17th, if you're in Washington, D.C. at 5 p.m., we have an event at Busboys and Poets on 14th Street, an in-person networking event to celebrate the launch of Health Affairs Insider. We're doing that in conjunction with Georgetown's new Department of Health. We have more events this month that you aren't going to want to miss. Please sign up on healthfairs.org/events to get on our mailing list so you know about them as they are announced. Again, thank you, Dr. Valdez. Thank you to the audience. We hope you enjoyed the conversation, and we are adjourned.
Thanks, everyone.